Well, let's call our meeting to order.
I call in the order at 3:03 p.m. Would you like me to take roll? Director Gallagher?
Here.
Julie Peterson? Here. Max O'Branje?
Here.
Jessica Dixon? Here. And Chair Pimentel.
Here. Any changes to this? Any public comments?
No hands raised online.
Yes, Kristen. Happy to be here. Great. Excited to get started.
Welcome. Comments from? All right, let's move on to our consent agenda. On our consent, our approval of the minutes from January 28th and February 25th. Do I have a motion to approve consent? Thank you. Is there a second? Second. Thank you.
Gallagher and Angie. Thank you. I'll take roll on this item. Director Gallagher?
Yes.
Julie Peterson?
Yes.
Max O'Branje?
Yes.
Jessica Dixon? Yes. And Chair
I mean, if there are no hands raised, no public comments.
Yes.
Item number 2, discussion of financial performance for February 2025.
Okay, I have quite a few things to talk to you about today, so we'll jump right into the presentation. February was a tough month for us, so I've got a couple extra slides just as we've done some drill down trying to get some of the storyline on that. As you can see from the consolidated month-to-date income statement, it's primarily in the net operating revenue. We're about $3.2 million unfavorable on net operating revenue for the month. Most of our expenses are within budget. The one area that we're very challenged with these days is the professional fees, the different position contracts. We've changed, we're kind of in that interim role on the hospitalist contract right now, and so we've got kind of an interim payment plan while we're trying to figure out, how that agreement is going to shake out. So that's been higher costs. We've been paying higher expenses for the radiology coverage, while we're also kind of in an interim role there. So that is kind of the big ticket item that is hurting us the most right now on the expense side of the house. I think I'll go to the next slide. I wanted to give a little bit of a perspective on a couple things that we saw in the month-over-month. There's been a lot of drill down, and I just wanted to keep it kind of high level for you. Starts out at gross revenue. January was a month with 3 fewer days, but it was also a month with $14 million less in charges. Part of that was that January's charges were high, and they were about $3 million or $3.5 million more than really just January, because we were still catching up on the charge capture from the cyber attack with the end of charges at the end of November and the first couple weeks of December. So what we saw in January was a little bit higher than just January. Overall, we had 350 less visits, but we still ended up with more visits per day in February than we did in January, by about 9 visits per day. And that's kind of a combined admissions and outpatient. Really, the extra visits are on the outpatient side, because you'll see that admissions were still down a bit. So the gross revenue per day is about $178,000 less. And that primarily comes out of service mix. That's just change in what you provided in January versus February, and I talk about that a little bit in the next slide. The net revenue was off about $210,000 a day, and that can be a combination of that service mix and payer mix, and I'll be showing you that in my future slides. So quickly, just to look at the year-to-date before we go into some of the volume and payer mix details. Year-to-date, we're $4 million in the hole. Not where we wanted to be. We really, at this point in time, given how we had budgeted to ramp up to our annual budgeted EBITDA, it was to lose money in the first, 5 months or so, but to gradually kind of climb our way out. And so February took us in the wrong direction there. Let's go to the next slide. So here's a little bit on the stats. You see that admissions are about 10 below budget, and primarily we saw that the admissions were down in med-surg, peds, and ICU. Now, peds admissions have been down because we stopped taking admissions other than the older peds. We stopped that in the fourth quarter as we were kind of redesigning how peds might look, because it's been a very difficult position to recruit for, to have pediatric competent nurses when you have a lower peds volume. It's kind of a challenging retention and recruiting effort. On the outpatient side, volumes were primarily down. Cath lab volumes were down because we're not open yet. And then the revenues were down in the emergency room. I actually have a list of different departments where revenues were down or up, but kind of some of the major drivers are just the ones I'm bringing up. And it really, while you'll see that ER visits were above budget and kind of continue to grow, this was the first time I kind of drilled into the acuity. Thank you for sending me that acuity. And seeing kind of how heavily weighted the lower acuity ER visits are. So that is something for us to just kind of keep our eye on as we're trying to understand the service mix and how it impacts our net revenue. Surgical revenues were down. We had lower volumes. You can see in the outpatient surgeries, we had budgeted for a higher volume, although just given the way we spread our volumes this year and the fact that last February was an unusually high month, the 162 is, probably should have been spread a little flatter, covered a few more months, but we had such a extraordinary last February that it kind of got a blip in the spread. But, you'll see on a future slide, we've kind of been bouncing around between the low 100s and the 120s, and so this is a little bit on the lower end. And then, outpatient volumes, visits, and ER visits, they both exceeded budget, but, we did have some places where we were down in volumes, specifically outpatient radiology, as we've kind of continued to deal with some of the equipment issues or sometimes staffing challenges. So it's interesting, I looked at all these things, at how we were down this month and this, and this, and then when I went and kind of looked at year-to-date and compared it to last year-to-date, we tended to be up in most cases. So it's kind of an interesting story. Our inpatient volumes, we've been below budget, and we have felt like we've been below budget for a while, but as you start to look at how the volumes have been increasing, and you'll see it in my admissions slide, we are actually up 11% over where we were this time last year. And where we're below budget is typically because of our extra initiatives, such as additional peds volume. Cath lab was mostly outpatient, but there could be some folks that could have ended up coming in through a cath lab and procedure, but we hadn't budgeted cath lab as an inpatient. Deliveries, and you'll see that in the upcoming slides, because we talked last month about how they're kind of continuing to climb back up to where they used to run, and we've been on a pretty upward trajectory for the last 6-7 months. Inpatient surgeries, last year about this time was when we were sorting out the whole, are we really capturing the right patient status of when a patient should be in observation versus admission, and that kind of turned all of our admissions upside down. And so while they still feel low to us compared to the way that they used to be, we're actually up 2% over last year to date. Outpatient surgeries, as I mentioned, last year we had such a phenomenal February, and then things kind of came back into line. So it just feels extremely unfavorable to last year's But I think it's one of those things, if you took February 24 out of the mix, it wouldn't feel quite so, out of the ballpark. And then both in the ER and the outpatient visits were up about 5% over where we were last year. It's really closer to 5.5 or so. Next slide. So, here's a good look. I like to keep this one in, even though we've already talked about admissions, because it just shows that, it's kind of been a steady upward trajectory. Every few months we have kind of a higher census, and we budgeted to have a higher census, but we are at least having a bit of an increase. Next slide. I switch this one up a little bit, as we're taking a look at acuity, and I kind of, I think of acuity in terms of, as the acuity is growing and the case mix is growing, we're either documenting better, we're getting sicker patients, and we're able to keep them and not have to transfer them out, and, acuity also drives reimbursement. So, we're starting to, take a little more focus to make sure that if there's opportunities that we have to drive acuity and in improving physician documentation, that we're gonna find those and work on those. And then if we can also, I kind of think of this as like a bit of a marketing tool, that if people start to believe we can keep those patients here and that we can care for them, then we'll keep more of them here. It's got self-fulfilling prophecy. So, and it is kind of nice to see, I was feeling like kind of at a low point last August and September. Whenever we get down below 1.4, I feel like pretty low. So it's been nice to see that it's kind of been on a little steady climb back upwards. Right. Average daily census, so we finished the month at 33. The bad news is we're not really making, budget in census. The good news is we are keeping length of stay reasonable to, what we're going to be paid for. But we are below, and, we're certainly still below our average daily census this month. Because, again, we budgeted for a few services that we're not yet doing on the inpatient side, and or sometimes it could have been a little bit longer length of stay. So it is impacting the daily census. Next slide. Outpatient and ED visits, the blue being the ER visits and the orange being the non-ER. Blue, for the most part, it's fairly flat. I don't think it always feels that way to the ED folks. I mean, still averaging, 98 or so patients per day. So they have their busy moments. Orange being the non-ER visits. They're still pretty healthy. We average, close to 110, 112 a day. But we are impacted when we have service issues with the equipment. Hopefully, as we've got initiatives that are getting started around new equipment with the bond funds and things, MRIs and CTs, we've got our eyes on some ways to bring that up. Next slide. Okay, here's your delivery slide, since we were talking about deliveries, and you can see the nice upward growth, from where we were, say, last June, where we had a low of 48. So it was a healthy month. Anytime we get over 80, it's a pretty healthy month for us. So 81. Here's the surgeries. The green being the inpatient, the blue being the outpatient. So we had 40 inpatients this month and 107 outpatients. I think we're a bit behind on the outpatient budget, but I usually think at this time of year some of those elective outpatients are also people are putting it off until they, because they know they've got potentially a copay or deductible still to pay. And then I think this is where we would have seen cath lab volume. So we know that there's at least 48 cath lab cases that we budgeted for in the first 2 months that are not here. Okay. So payer mix. definitely one of the contributors to the net revenue this month. And where we saw the biggest shift was between the commercial mix and the managed Medi-Cal mix. Commercial was down about 4% from last month at 14.5, and managed Medi-Cal was up 4%, up to 46.5. So that's that's about a 10% difference in reimbursement rates between commercial and the managed Medi-Cal. So certainly has a few $1 million worth of impact to us. On the outpatient side, it was generally more flat. We were up 1% in Medicare, and it just offset, mostly in commercial and managed Medi-Cal, but it was just 0.5% in the commercial and a little bit in the 0.1% in the managed Medi-Cal. So it was kind of spread between. So while we've been seeing some additional Kaiser volumes since we've been now with the full hospitalist group, they've now opened the MOB in Salinas. We have not really gotten to the point of studying, are the increased volumes from Kaiser coming from Salinas or just coming from a more local pool. But we have seen more Kaiser patients in the last couple months. So we take that as a positive, since we want that partnership with them, and we are their hospital on this side as a host here. I'm going to stop there for just a second because I'm going to change gears. So ask if there's any questions on the monthly financials.
Do you have an inkling why this 5-month trend of fix something is?
I don't know of anything different that we've done in particular.
At the moment, Medi-Cal, our AR is growing, right? That's a combination. Is it even related to constantly or adoptions of presidential policy changes, which acting the speed with Medicare's reimbursement? Is there any sign that there's something abnormally different with how to go?
We're actually kind of recovering from the abnormally different stuff. So there could be that underlying, and that's not as visible to us.
Yeah.
Our AR actually went down, get the exact dollar amount, from last month, because so much in January was still hung up in us trying to get the catch up the backlog done, the bills out the door, the bills back, the payments back in. We didn't really see the first significant payment that impacted the cyber attack until February 28th, and it wasn't actually related to the cyber attack. It was actually related to us getting the Medicare MPI issue cleaned up. And we got $2.5 million on the 28th from Medicare because we had a huge backlog. They're still recovering from that backlog. We've already had a couple nice payments this week, not to that magnitude, but anytime it's more than $50,000, I'm pretty happy.
Yeah.
March we've recovered with some of our cash because some of those payments are now starting to come through. That's probably what also kind of shield us from seeing what else might be going on there because of administrative change.
Starting to have a little bit of relief in the AR, it appears our allowance for AR stays static, but our AR balance is growing, and it went from 40 million to 50 million. I'm wondering if our AR allowance is undervalued. The valuation that base.
Yeah.
But I'm concerned that the AR allowance stays flat, yet the AR total is growing.
I haven't focused as much at looking at it that way as much as I've drilled into, am I comfortable with how we're valuing the AR? I've had Jessica and the team doing a lot of dive down to do we understand, can we put something behind our AR valuation that says, okay, that result makes sense to me, or it doesn't make sense to me. So rather than looking at it in kind of just terms of the gross dollars like that, we've looked at, you know, how has the payer mix shifted, how has the service mix shifted, you know, some of it is, the quaff and dish payments are kind of buried in there, and we were allowing for, like less dish because we were of the reduction, that's one of my bullet points, so I'll touch on that in a minute. So, my gut feeling has always been that we are not undervaluing the AR. If anything, we're being overly conservative. But I've been really much more focused on the fact, why does it fluctuate so much month over month? Why has it been as volatile? So we drill into things like high dollar accounts, aged accounts, things that we can go back to Guidehouse doing our collections and say, you know, get into the details. I believe we still have, you know, more aged AR than I think we should have that should be collectible dollars.
On expecting, when might we be able to get a budget actual metric for the gap lab? From a quantity perspective, we expected 37 this month, yes, we're at 0. So I guess I'm putting out there, 1.9 would be helpful to see those kind of combinations, more than just a dollar was off budget by X.
So you're asking for something a little more detailed than the high level metrics.
Well, I think the high level works, but are those
These
dollar values or those?
are volume values.
Oh, I'm sorry.
Yeah.
Maybe I missed that.
But we do have, yeah, those are the higher volumes. I mean, you know, we do have, especially, but I'm gonna say especially like in the outpatient, because, you know, Steve has been tracking as part of his dashboard that he presents to the board, and Vanessa's put together a nice thing, because Matco also tracks a subset of that for some of our internal work, where we are, you know, starting to look at, okay, where were we off in radiology visits, or where were we off in pediatric visits? And I'm also thinking about it in terms of, you know, I'm not sure if it's a stoplight report or something else that says, okay, these are the initiatives that we budgeted for, you know, year to date. Are they red, yellow, or green? You know, are they producing yet? Are we behind? You know, so we are kind of thinking along those lines.
February, the material impact from our MRI scanner and having to bring in the second unit. I mean, I'm sorry. Okay. I just wondered if that was all part of the narrative of like February.
Yeah, I kind of wrapped that up into, I just said outpatient radiology in general, because CT was a big piece of it. Ultrasound volume was down. Excuse me. Those were the two major radiology ones that were gross revenues were, you know, significantly below budget. It's interesting though, because we were definitely impacted in February because they're actually more favorable on a year-to-date basis, but not the month of February. Okay. So on to some other news. Okay, so the first one is the good news. Yesterday afternoon, I received the letter that says our loan modification has been approved. So we will get 12 months of deferred payments. That's about a $1.8 million deferral. Hopefully, phase 2 gives us a chance to just get forgiveness on that 1.8. But for now, they have approved that, with, you know, pending us filling out the papers, which are pretty basic. We're actually going to talk about that in the next one of the next agenda items. But they did make some other adjustments to that program as well, in terms of making it a longer program. So even when it goes into repayment, it's got a longer time to repay. But again, I'm hoping that they decide to start lopping some of that off. So that was the good news. Couple other, decent news things, oops, back. We've been, every year we kind of live under, dish cuts are coming, oh, they've been postponed. So nothing's changed here, but we did get the news, that dish cuts that were proposed for this year that were kind of seeming more likely. I'm not exactly sure why, but they've been at least postponed to October, maybe they'll, get postponed further. The good news in that is that most of the that money that we receive, we will have received by October. So if it gets postponed that far, it's a pretty good sense that we will get our dish money for the dish year, which is a 24-25 year. And so by having the cuts postponed, that gives us a little more assurance for about $800,000 that we otherwise were kind of hedging our bets on. The QAF 9 model, that should say QAF, not QAB. The QAF 9 model is, the next QAF program that's out there. We're in the middle of QAF 8 right now, kind of more towards, well, not the tail end because it goes into 26, but they need to have the model to CMS by, I guess it's next Monday, and assuming they make that deadline, then we should get our first real previews into what that looks like. All the kind of rumor mill says that it should be better, significantly higher, that, DHCS is going to get a larger increase to the directed payment program, which would definitely, that's where we get the bulk of our dollars now. That would definitely help us. The uncertainty is what's the scrutiny that's going to happen, given all the changes. So the fact that they'll probably have additional scrutiny says it'll probably take longer to get approved, so we're not expecting much this year, but I still like to remain hopeful that maybe something, is available by the fourth quarter. And I would like to be extra, hopeful that some of that they actually start the program in the fourth quarter. I don't know how likely that is, because I know a couple, maybe it was with QAF 8 that one had been supposed to start earlier, and it kind of got delayed into the new year when it started. But good that it should be moving to its next step. Accounts payable backlog continues. We still have a pretty healthy backlog. The fact that our cash collections did improve this month, we have been able to make some larger payments than we had been making. But I'm also kind of in it's a balance between what I got to pay and I got to stockpile because it's a long time till that next QAF payment or that next, kind of infusion. And there's still, we've got initiatives to roll out, we're kind of riding the bubble of the cyber cash coming in, knowing that at some point it'll kind of return to normal unless we grow volume. So it's a delicate balance every week on the AP. Okay, a quick stop there because I'm going to change topics one more time in this thing.
Well, keep coming up in our other conversation, every level of areas that are under. So, yeah, I agree with you. It's unfortunate. And I have them also.
Yeah.
Has cash gotten more predictable? Cash income?
Not necessarily. It's we're riding the wave of catch-up right now, so it's been better. But almost every day I'm kind of like, when is it gonna drop back? And the data that I get in, I haven't had as much time in the last week to really study it because I can sometimes say, okay, maybe I can see a week or two out. Beyond that, I'm kind of still riding a little bit blind. Okay. So the other thing that I wanted to talk about, and this is partially in a way to maybe introduce to this group that some visibility over retirement activities that go on, the retirement accounts that we have. This is a new retirement plan that we're actually putting together for the Coastal Health Partners group. They had a plan previously under the old ownership. They weren't able to just roll that into a new plan at the time of the transition, so they've been without for the last 2.5 years. So we've been working with our new retirement broker, Alliant, and our record-keeping keepers, the principal, to define a plan for CHP. Now, right now, the CHP plan would have about 10 participants. Hopefully that will grow over time as we're able to recruit into CHP. So we've created a plan, along with Alliant helping us, and it's a plan that, for all intents and purposes, we're kind of, administering and keeping it going, but it actually is administered by Coastal Health Partners because they're a separate corporation. So the technical administrator will be Coastal Health. We do believe it'll be a physician satisfier because we've had a few of our existing docs ask about it, and it should also help us in recruiting in the future. The name of the subdivision of principal is called Simply Retirement, and we spent time last week with them or 2 weeks ago, kind of putting the basic guts of the plan together. They'll have kind of the usual deferral abilities like any other plan, following the IRS limits, and they will be allowed to roll over other retirement plans that they have if they so choose to do so. So even though it's kind of a simpler plan in some respects, it seems to function very much like any other plan. A couple of the high-level elements of the plan design. Any doctor who's here when we implement this will automatically be grandfathered in from day one. But much like we do with our employee plans, anybody else who comes in after the plan's in effect will have a 3-month waiting period before they can enroll. The plan is designed to have auto-enrollment, and I guess this is just one of the features that most plans are being kind of directed because there's people above us have decided that people don't save enough for retirement and we should be helping them. So anybody can opt out, but if they don't opt out, it'll automatically at least enroll them in the plan with a 3% deferral. The deferrals are all basically physician-based as they choose to make the deferral. These are not contributions from the hospital or the district. They're physician-based contributions. Much like the other plans, you can have the auto escalation or you can opt out of it. It just each year incrementally increases how much you're contributing up to the point that you hit that IRS limit, sometimes partially through the year. There's the opportunity to do, pre-tax contributions, Roth deferrals, loans, hardship withdrawals. So again, I say it's pretty much your typical bells and whistles. And it's got a nice investment lineup of different types of funds that the physicians can enroll in, including things like the target date funds that are very popular with most people who don't really want to think about it and want somebody else who's done the research and the studying to, help with. But certainly there's options for those that might want to spend a little bit more of their time figuring out how they want to manage that. And then I guess, one thing about this is much like we do with the hospital-based retirement plans, we'll have like an annual meeting. We do it semi-annually, I think, on the hospital side, bigger plans, but, kind of reviewing the investment lineup. The brokers do all the work to make sure how healthy are the plans, do they have any watch indicators, things on them, what are the rates of return, and helping to advise us if we might want to consider other changes. So this will have the same. Next slide. And, the plan fees are relatively minor, one-time setup fee, monthly administration fee. The monthly account fee is per participant, so right now it might cost us $60 to $70 $5 a month. Custodial fee, pretty small. And the last two fees are actually those fees that any participant would see right on their statements, and pretty industry standard. So I really just kind of wanted to bring this to you for visibility. We kind of went back and forth of whether we thought it needed any kind of approval, but we're putting the plan together, but it's not really our plan. So it's kind of an oddity of just our structure.
We use the hospital.
Well, I mean, this is where it's weird, because you've got the district is the legal owner of the clinic. The physicians are employed by Coastal Health Partners, and we have a professional services agreement, so while we employ the physicians, we still have to have that kind of arm's length transaction. Yeah. So that's why we kind of, we're confused by this for ourselves, is like, so who's actually, I mean, for all intents and purposes, I will be the plan administrator like I am for the hospital accounts, but I won't be the one signing on the line as the plan administrator because I'm not an officer of Coastal Health Partners. That's the best way I can explain it. That should be the last slide.
Brain is going to different, 401 and 457, they're model on very used to on the government side, and they have a little bit different variants that kind of look up.
Well, so here's kind of the best way I think about it. Our employees, where we make contributions, which are like the union employees, the non-management employees, they have 401As because we're a government agency and we're contributing. If they want to do their own contribution, they also have a 457. That's where the employee can contribute. So we, for those employees, I got two different plans. So the physicians, and those are non-ERISA plans. For the physicians, they're a separate entity. They're not eligible for a 401A. That's why we couldn't just add them onto our plan. They actually go the ERISA route in the 401K. All I have on the financials performance.
Just going back to, remember Gallagher asked a question about cash and how we're doing. Like March balances got a little bit better before in.
Cash coming in the door has got better. We still have a pretty healthy AP backlog. Yeah.
Any other questions on February financials? Next item. Chair appointment. So, item number 3 is recognizing that we haven't appointed a vice chair, and we have my left. So, Gallagher, member of the board of directors, appropriate to have a member of the board of directors serve as the vice chair. So, recommending that we pass a motion approving the appointment of Dr. Member Director Gallagher as vice chair of the Tar Valley Healthcare District Hospital Corporation Finance Audit Committee, and that we forward this recommendation to the board.
I support your.
I dealt with paper.
Yeah, sorry.
Do we have a motion?
Member 6. I'll take roll on this item. Director Gallagher?
Yes.
Jessica Peterson? Sorry, Jessica. Jessica Dixon?
Yes.
Julie Peterson?
Yes.
Vasco Rendez?
Yes.
So at the time we put this on the agenda, we were kind of being proactive, and since we now have approval, one of the things that we have to do as part of the signing the final paperwork, you know, we'll get a new amendment to the loan and security agreement. I have, there's a copy of substantially what it looks like, without all the blanks filled in of, you know, name and things, because we didn't have approval at that point. But we're gonna bringing this forward for a resolution to basically authorize us to execute that agreement so that we can get this loan modification done. And I have, I think, a new copy of it in my email today, because I've got to verify, which I know we don't have any covenant defaults, but that's one of the questions they want us to validate for them. So this item is basically to ask for approval to the First Amendment as outlined in your packages, and to allow us to execute that. And here was the point where it was like, where this was originally 72 months with an 18-month grace period, it's now like 80 months with a 30-month grace period. So we have, and so I'm asking for this, I guess this is, we're talking about here, to take this to the board, to have the board approve the attached resolution.
Board part of the resolution was very good. I appreciated that the resolution was adding flexibility to allow staff to monitor. But the board is approving it as a form, and staff can modify it by, I asked that, put in the motion, we asked the board, have it come back to us, the rest of acceptance file. When it is final, it comes back to the board on consent.
Okay, yeah. It was nice that the program itself put all this language together, and that they had recognized that they wanted us basically to get this resolution as part of executing the documents, so that you had to have that little bit of flexibility.
Well, I was probably still creating time. We have a motion and such, that the recommendation of the board that when executed, that comes back to the board as a acceptance file. So moved.
Members Gallagher and Dixon. Okay, I'll take roll on this item. Director Gallagher?
Yes.
Ms. Peterson? Jessica Dixon? Looking right at you. Jessica Dixon? Yes. Sorry, Julie Peterson? Matt Gilbrandt? Jeffrey Mandel?
Yes. Our attorney.
Thank you.